Good afternoon, everybody. So we are on an electric train now. We don't have any engine. So I'm Ranjit Singh Dhaliwal from Nabha. I'll be starting my innings here. I come from a very small place, Nabha, a population of less than 1 lakh, surrounded by a vast rural hinterland, is connected to Delhi by just 2 trains. A saving grace is we have an international airport within 90 kilometers of Nabha, which is a better situation than all those metros, Delhi, Bangalore, Bombay, etc. This presentation, as all my presentations are dedicated to Vikram, I'll be speaking on why MSICS. Well, just for one reason, because it is a surgery for all seasons, a surgery for all reasons. Ophthalmology today is on its cutting edge. Better, not necessarily the finest equipment, in association with absolute dedication to ophthalmology to provide personalized care to even such patients, free or at a cost affordable to them, is the necessity. The aim is to provide dedicated professional care. Improvisation and indigenization brings the latest technology to the multitudes of masses of our country at a reasonable cost. A modern setup at the primary level can also boast of quality services and does not cost a fortune, I would say. So, why is manual SICS a surgery for all seasons, a surgery for all reasons? India, a land of vast disparities, presents at any given time a linear panorama from ancient couching, it's still there, to modern phaco. Manual SICS fits in at all levels, a surgery from primary to the most advanced level of patient care. Cataract surgery is no longer a simple rehabilitative procedure. It's an extremely precise refractive surgery, the goal being emetropia. It used to be emetropia, but now we are using astigmatism also to our advantage. It is an easy, provides all the advantages of a small incision with few complications. It has a hazard-free, smoother and easier learning curve, rather no learning curve for one already into ECC and implant surgery. Well, I wonder if people are learning ECC anymore. It is, in fact, a revolutionary technique ideal for teaching institutes, government tertiary centers, and wherever finance is a constraint. It has arguably the same objective and results as phacoemulsification, presumably not a single absolute contraindication. Charm of SICS is its simplicity. Repeatability we have to add on our own. It is a no additional cost option and little extra investment is required. This is the only place where we differ from the phaco people. Nucleus in management in SICS is a single step procedure. This one was around 9 mm size. And we were able to, these are two different cases. In one, we took out a cord and then rotated the lens out. The other was brought out straight away. The nucleus can be delivered with a fish hook made of 26 gauge needle and an irrigating vectis alone, or by the sandwich technique, or by the hydro or visco expression technique. Cases of cataract coexisting with most eye comorbidities have all been taken up for manual SICS at our center at one time or the other. Manual SICS is a must for a phaco surgeon for times when he has to convert phaco machine failure, posterior capsular rupture, zonular dialysis, hard black or brown cataract, or having used too much phaco energy. A phaco machine and the paraphernalia that goes with its instrumentation, sterilization, repair and replacement are a costly luxury for small clinics, though everybody is going for it now. My most controversial slide. Phaco machine out of order, the ordeal begins. Sales and marketing teams, efficient, slick, and polished. After-sales service department, callous, indifferent, and unreasonable. The number of WhatsApp groups fighting J&J and so many other companies are a witness to this. The less said, the better. Phacosurgery has a hazardous and steep learning curve and arguably is a time-consuming procedure for people other than the masters. Common problems faced in cataract surgery can all be tackled with manual SICS. I have listed them below. Temporal surgery can be a boon for patients like this, and a superiorly placed trabeculectomy bleb. Traumatic cataract and pre-existing defects are no contraindications. A difficult situation, a simple solution, not related to my talk. Another case of deep-set eyes with a narrow palpebral fissure. A lateral canthotomy did the wonders. Temporal approach, the advantages are the external scratch incision may be placed right on the limbus. By opting for the temporal approach, we are able to bypass the eyebrow in a deep-set eye, and the bridal rectus suture is not necessary. Irrigating fluid flows down through the lateral canthus, so no chances of backflow of the fluids. Advantages include in oblique astigmatism, this can be slightly modified. The tunnel is moved superiorly or inferiorly, placing it tangential to the steep meridian. Superiotemporal approach is also used in cases having no astigmatism. This was one of our post-op cases, 1 day post-op, 6x6 unaided. And I put up this slide just because I like this picture. And in manual SICS, the final results are arguably extremely good in the learning period, but fascinating once the technique is mastered. So that's my grandson trying to figure out what all is happening around. Thank you for your patience. Thank you. And any questions? I don't think I've left anything for that. So, thank you, ma'am. And let me call over the next speaker, please. I'll be running off.
Okay, so good afternoon, everyone. We speak to each other. And I'm Dr. Rashmi Jain. Could you please change the slide here, the front display also? Thank you. So I'll be speaking about, can I start? Yes? Okay. So I'll be speaking about screening for retinopathy of prematurity, a competency-based training program. Just think of the statistics. ROP screening, something which is done by general ophthalmologists, but no, more than that, mainly by retina and the VR people. About 20,000 ophthalmologists in India, just a few hundreds, maybe about 200, vague range, are the ones who are VR surgeons and actually doing VR screening. 3.5 million babies, premature, born each year. We definitely have a gap where we need to train more people to screen for ROP. Traditional ophthalmology residency training does not train people because of limited exposure to this particular thing of ROP screening. Let's talk about competency-based training. This training, as contrary to the traditional one, emerges from health need, that's our need, to have more people. It defines its outcome or competency based on what we require, train people, defines its curriculum along that, and we devise the teaching, learning, and assessment strategies based on exactly what we need. What does that mean? Let's train them in all the domains, not just in knowledge. Knowledge, of course, the skills of patient care, the skills of procedural skills, the attitude or communication, that's professionalism and communication. When we talk CBME, we say we define objectives. These are the specific objectives. And there is year-wise progressive outcome. We focus on what a learner should know. And it provides clear specific goal for what the teacher, the student, as well as the assessor or the examiner or the nation as a whole needs to know what is our training. Year one is a foundational skill training. What's the outcome? Observe and assisting a newborn ocular screening. Note, I did not use the word preterm, just a newborn ocular screening. We talk in different domains of what we are going to teach, starting from basics of the knowledge, patient care, professionalism, and there is one extra word added, the teamwork. So here the students just learn to work in interprofessional team. Learn to work with optometrists, learn to work with pediatrician, learn to work with nurses around. Second year is of supervised clinical practice, where they'll be able to do independent newborn ocular screening and supervised ROP screening without speculum. We increase the level of each of the domains what we are talking, whether it's knowledge, the skill, or the professional and communication. Now look at another important part, the teamwork. That's interprofessional working. Earlier they were just part of a team, now they are working in a team. Huge difference. I can be part of a group but not work with them. As they grow older in their training, they start working with the team. The final year is when they learn about entrustment and independent performance. What's the outcome? Independent ROP screening with speculum and camera imaging. Now here, as a team leader, as a part of the team, as they become senior, they learn to manage interprofessional. Look at how the knowledge changes. Now they'll be able to observe and actually stage and classify ROP. They'll be actually able to try and use speculum, staging, identifying various things, working in a team together. What are the strategies we use to teach? Interactive lectures, supervised clinical practices, role play, simulation, peer-assisted learning, reflective portfolios or e-portfolios. Assessment plan, what's the major? So many things here. It's different for each year. Why is it different? Because we taught different things. As we increase in the year, our assessment changes from simple question answer or MCQ to OSCE to DOPS. Where towards the end, we even ask them to reflect. We take a 360-degree feedback. Initial year, the feedback is just from the sisters, mainly, because that's whom they work with more. As they grow older, the feedback comes from their juniors, how they're managing the sisters, everybody who's around them. What is it that we expect? The expected outcome. We expect through this competency-based program to develop a skilled ROP screening team, where our expected outcome would be improved neonatal eye examination, care skills even in a resource-limited settings. So here, the basic ophthalmologist gets trained in not just screening a baby, any neonate, a preterm baby, and also in a medical college or a eye care setting. So every facility is not available there. That's what we would emphasize on. Very, very important, enhanced empathetic communication skills with parents with vulnerable population. Remember, children who are in NICU. So they learn the skills how to communicate with them. And of course, the most important, improved teamwork skill. This is what we would expect when we train in a competency-based system. What's important for us to understand, when I talk of future direction and scalability, what am I thinking? We are just using this as a model for training ROP. The same model, the same way can be upscaled, scaffolded on training other components of our branches. So when I say 3 years, you might wonder, ROP for 3 years? No, it's not just ROP screening. It's multiple things which we scaffold, which we teach in a structured pattern. So this is what is a stage-wise, outcome-based or a competency-based program for anything. Here we focus on ROP screening. So what's our aim here? Let's build, sorry for the typo, skilled interprofessional ROP screening teams so that no baby goes blind because we were not there to screen them. Thank you so much for your patient hearing.
Dr. Gurvinder, can I have my PPT? So should I start? Okay. So Good afternoon, everyone. As Dr. Ranjit told, no, we need to tell ourselves only. Sometimes we don't have audience. Sometimes we start with a small gathering, and we just hope that it becomes a bigger gathering in near future. So my topic for today is non-ophthal. It is a very unconventional topic, but it is very dear to my heart. So I always speak in almost all the conferences. I speak the same PPT, thinking that it will reach the masses. So the equal hands to heal, the case for disability inclusion in medicine. Rather than a talk, this is more than a food for thought. So everybody knows Steve Hawkins. He was a physicist and a very severely impaired, disabled person. Hallel Keller, everybody knows, was blind and deaf. Aruna Sani and Zia Boy, they both scaled Mount Everest and they were lower limb amputees. Our own profession, Dr. Suresh Advani was a lower limb impaired oncologist. Dr. Satinder Singh is still professor in physiology in UCMS and he has a lower limb impairment. Dr. Sharad Philip happens to be my student, is AP in psychiatry in AIIMS Guwahati, and he is blind. Dr. Tim Corden is a blind physicist. Dr. Blake is a dyslexic cardiologist. Dr. Chris is a lower limb impaired pediatric surgeon. And Dr. Dinesh is a quadriplegic emergency intern. Dr. Amanda is hearing impaired family medicine doctor. So with these thoughts, these people have amply proved that disability is not a hindrance to get into a medical profession. So according to the Rights of Persons with Disability Act 2016, there are 21 listed disabilities. There are rules and reservations. More than 40% disability people are eligible for the reservation, and 5% horizontal reservation across all categories is there for the UG and the PG medical courses. So now if there are rules, there are regulations, then where is the problem? Why there are so many cases who are going to the court to get admission into the medical profession? The problem lies in our guidelines which we have made for the UG and the PG curriculum. They are readily available on the net. These are not made by me. So we will get a brief insight into these guidelines. For MBBS curriculum, if I have the ones which I marked green, if you look at the blindness category, so less than 40% disability is not eligible for the reservation, more than 40% is not eligible for the course. So there are many disabilities where there are no clear-cut guidelines. So we have also made guidelines for the PG curriculum. So there we go one step ahead and we tell which disability will do which profession. Just think of somebody telling me I can do this, I cannot do this, how bad it looks. So looking at the ophthalmology profession, only the limited lower limb disabilities people can do the ophthal, or a mild acid attack victim can do, or a blood disorder person can do. Just sit and think of who actually can do ophthalmology. So why these guidelines are not acceptable to persons with disability? Why they are going to the court? Because the stakeholders are not there. So stakeholders need to be there when the selection, the guidelines are set by the committees. Because the persons with disability, they understand their needs and the capabilities both. Then there are many guidelines which say that we cannot provide reasonable accommodations, or they are not feasible to be provided. Now what does a reasonable accommodation mean? In our house, if I have to change a tube light, I need a staircase or a chair, so that's a reasonable accommodation. So providing reasonable accommodation is the responsibility of the society and the right of persons with disability. Nowadays, if you go to CBSE site, till +2, all the books are available in the audio form on their website. So that is a reasonable accommodation. So why cannot those books be available in braille and audio in the medical profession also? And then what is the reasonable accommodation? You need elevators, you need ramps, and they say the elevators are not working, the ramps are not there. If they are there, they are very crowded, they are inaccessible. Do you think these accommodations are needed only for PWDs? They are needed for patients also who reach the hospital. And nowadays, almost all the hospitals, all the buildings need to be made disable friendly. So then there are very derogatory remarks in the guidelines for persons with disability saying that we cannot reduce the standard of medical education. We are a competency-based medical profession. At the end of the profession, there is an exam. Everybody needs to pass. Lowering the standards doesn't come. And a case-to-case assessment is very important. You cannot have blanket exclusion of disabilities. And you cannot tell what they can do, what they cannot do. You're going to take an exam at the end. If you do not feel they're competent enough, don't pass them. Having doctors with disability will make this profession more sensitive, more patient-friendly. Patients actually relate to people who have the same kind of disabilities more than they relate to us. And then there's another thing in the guidelines saying that the IITs, the NITs, they do not take people with disability into their courses. This is not true. My own son is in an engineering college, so this is not true. And if it is true also, medical profession is an institute in itself. We do not follow others. We make examples for others to follow. So I'll just conclude with 2 slides. The present guidelines are against the spirit of inclusion of PWDs into medical education. We need to change our mindset. We need to have a more positive approach towards people with disabilities. We need to give them equal opportunities. We need to believe that they can do things as good as or even better than us. We should allow the persons with disability to decide for their choices, and we should not be doing that for them. And having doctors with disability will make this profession a beautiful profession. They are going to be an asset and not a burden. I'll sum up this talk with beautiful lines by our Chief Justice in 2021. While delivering a verdict on the persons with disability into medical education, he said this: when competent persons with disability are unable to realize their full potential due to the barriers posed in their path, our society suffers as much, if not more, as do the disabled people involved. For it is denying to the nation the opportunity to be served by highly competent people who claim nothing but access to equal opportunity and a barrier-free environment. And if this is also not enough for provoking some thoughts, let us ask one question to ourselves. What if I become disabled today due to any reason? Will my stand still remain the same as I have now for persons with disability? Thank you. I don't think there are questions.
So first, very good afternoon to all present here. And I must congratulate you, Dr. Kaur, for a very, very good presentation. And what a way to be involved in such a great thing. Congratulations to you and your work. I hope it reaches the masses also. The way you want it, we all desire the same. So my talk is going to be a multiplex PCR, which we developed in our section for the detection of herpes simplex viruses type 1, type 2, cytomegalovirus, VZV, and adenovirus in oculoviral infections. I don't have any financial interest or other interests. So oculoviral infections, we know that they can range from simple self-limiting discomfort to possibly vision-challenging manifestations. However, we all viral infections need an accurate and rapid confirmation of the pathogen for correct and timely treatment, as well as for follow-up and specific sequelae and complications. So the most common viruses causing ocular infections are herpes viruses, including HSV1 and 2, CMV, VZV. Also, few serotypes of adenoviruses. These are all DNA viruses, and enterovirus, which is an RNA virus. We understand that it is difficult to diagnose the pathogen solely on clinical examination, and the conventional methods are less sensitive and specific, and they are having a long turnaround time. So in recent decades, molecular diagnostics, of which polymerase chain reaction is one, they have become very popular because they have proven themselves to be very valuable. Now, in brief, polymerase chain reaction involves looking for a particular genetic target of a pathogen and then amplifying it. That is, making a lot of copies of it by using the steps of denaturation, annealing, and elongation. And after a lot of copies of that particular signature target of a pathogen have been created, then we do some procedure, usually a post-PCR gel electrophoresis, to detect that amplified genetic component. Now PCR has a limitation that if there are a lot of pathogens in the differential, then we have to put a separate reaction for each of the pathogens. That makes the diagnosis very time consuming, very resource demanding, and also very error prone. So multiplex PCR is a variant in which all the pathogens in the differential can be diagnosed in a single PCR, thus saving on time, cost and hands-on work. So in uniplex PCR, if these are the three targets which we want to amplify and diagnose using reactions, separate reactions like this, it is possible in multiplex PCR that 3 to 5 pathogens can be tested in a single tube. We do the titration of the reaction conditions in such a manner that all the targets get amplified and give a reaction like this. So we started with the objective of establishing and standardizing a multiplex PCR for detecting pathogenic viruses from ocular infections, and we could multiplex only DNA viruses. The herpes viruses and the adenovirus, the RNA virus, enterovirus could not be multiplexed. So we first standardized 10 uniplex PCRs, 2 each for HSV1, HSV2, CMV, VZV and adenovirus. And the results of uniplex PCRs were checked in control strains and known positive specimens for different study viruses. Next, we started the very tedious task of multiplexing, where the uniplex PCRs were run at different annealing temperatures and with variations of cycle conditions to obtain the annealing temperature and cycle conditions suitable for all 5 viruses, and various multiplexing combinations of the PCRs were put to diagnose all 5 viruses in a single reaction. So we finally got the 5 targets, annealing temperature and reaction conditions giving best results for all viruses of interest. These were the targets and the primers, and these were the reaction conditions which were finalized to give us results like this. 5 viruses in a single reaction. So the multiplex PCR was again run with control strains and known positive clinical specimens for different study viruses, and the uniplex and multiplex PCRs were then run for the study samples and controls. It was found in this study that the sensitivity and the specificity of our multiplex PCR was very high, and in real life scenario from the ocular specimens we were able to diagnose all the 5 viruses which we were interested in. We were able to get very good results from the non-invasive samples like conjunctival swabs and tear samples, and also we were able to diagnose posterior segment infections which are otherwise very difficult to diagnose. And the multiplex PCR was immediately put to use for diagnosing ophthalmic viral infections in our patients, and these are the results of our routine testing. In viral corneal infections, HSV1 followed by adenovirus are the most common viruses. In conjunctivitis cases, adenovirus followed by HSV1 are the most common pathogens. Also, in July 2023, we encountered an outbreak of EKC, and there we used the same multiplex PCR as well as a uniplex PCR for enteroviruses along with the other microbiological techniques. And not only that we were able to diagnose the drivers of the outbreak, adenovirus and enterovirus, we were also able to diagnose herpes simplex virus in 3% of the cases because we used this multiplex PCR. We could have missed HSV cases if we were using a uniplex PCR only for adenovirus. So to conclude, we have established a good, robust multiplex PCR technique which uses less resources and time and is less error prone. It has stood the test of time in routine diagnosis of otherwise difficult to diagnose cases, and it has also proven its performance in the challenging time of an outbreak. Thank you for your patient hearing. Thank you. So I now invite the next speaker.
A very good afternoon. It's a very nice, pleasant experience to be presenting this way. So my topic is again a very controversial topic, is complementary and alternative medicine in ophthalmology. What do we know and what should we know to go further? I do not have any financial interest. I do not have any conflict of interest. So exactly what is CAM? CAM stands for complementary and alternative medicine. It is said to be complementary when it is used along with the mainstream medicines, and alternative when it is used instead of them. And in addition, we use another term, that is traditional eye medicine, which are biologically derived therapies from plants or animals and which are applied in the eye or around the eye. So why are we talking about CAM today? We are talking about CAM because there is a big Government of India push towards the other streams of therapy, which are termed as AYUSH. AYUSH stands for Ayurveda, Yoga, Unani, Siddha, and Homeopathy. And we have central agencies for Ayurvedic research, homeopathy research, Unani medicine research, and all of them are promoting the use of CAM as integrative medicine. In addition to that, we also have integrated MBBS courses starting soon. So in ophthalmology, where do we stand regarding CAMs? We have the traditional systems, that is Ayurveda, Yoga, Unani, Siddha, Homeopathy, or we can have nutritional or herbal therapies. We can also have acupuncture or mind-body practices. What is mind-body practices? Mainly meditation, yoga, and the pranic healing support system. We did a survey to study the awareness of CAM in ophthalmologists. We had a participation of around 255 ophthalmologists, and this survey highlighted the knowledge gaps regarding CAM in the ophthalmologists and the patient interactions with complementary and alternative medicines. A good 75% ophthalmologists were aware of CAM, but only 30% were open to discussing CAM, even when 63% discussed CAM with their ophthalmologist. And almost 38% they noticed that CAM was used amongst patients. In your practice also, you might have come across patients who were using CAM. So for us to have the knowledge of CAM is to find better ways either to incorporate it or to tell our patients, no, it is not good for you. So why do patients use CAM? They use CAM because they're seeking symptom relief. Mostly they're seeking symptom relief. If they do not have symptom relief from your allopathic medicines, they will go to other systems of medicines. And then they believe in the safety. They feel natural is better. Then their cultural or family might support the use of traditional natural methods over the use of allopathic medicines with the so-called side effects. And what does this cause? This causes a delay in diagnosis and in many a case the loss of vision also. There is potential toxicity from heavy metals, and unknowingly there can be a drug interaction as with ginkgo biloba and anticoagulants. So what do we need to complete this circle? We need to find out about CAM and see if it fits it into the overall care for the patient. So where do we stand? What do we know about CAM? So CAM has basically been studied in a number of diseases, primarily in glaucoma, in diabetic retinopathy, ARMD, dry eye, retina pigmentosa. So all of these diseases, as we know, are chronic diseases. In glaucoma, ginkgo biloba has been studied to a good extent, yoga, acupuncture, and in them, the studies which we have been conducted in them, they have found that there is a good neuroprotective potential, but there is weak evidence. In diabetic retinopathy, antioxidants, herbal extracts have been found to be good. They use the oxidative stress, but they have limited clinical validation. ARMD, we know the ARADS formulations, we know it works, and it is used very widely. Dry eye diseases, omega-3 fatty acids are used, acupuncture has been used, Ayurvedic Netra Tarpana has been used with some benefits. So at least symptomatic relief is said to be there, but trials are needed to validate it. In RP, Ayurvedic Rasayana has been used, acupuncture has been used. Again, symptomatic relief, but need to be validated. So coming to glaucoma, where maximum therapies have been tried, natural compounds like ginkgo biloba, saffron, coleus, bilberry, all of them have been tried. Review articles have been published, and they say that neuroprotection is offered, but lowering of intraocular pressure is either transient or limited. Yoga practices, Jyoti Tartaka, and breathing practices. In breathing practices, 365 breathing has been advocated, urinostril breathing has been advocated. Again, the lowering of IOP has been seen, but does it translate into controlling glaucoma? That we do not know. Acupuncture has been tried, but there is very limited clinical evidence. So overall, what do we see in glaucoma? We see that theoretical benefits are there, but rigorous clinical trials are needed to validate it. So what are the main risks and the safety challenges of using CAM in ophthalmology? So mainly, as we said, delayed diagnosis. A patient sitting in a rural area with a corneal foreign body applies some traditional medicines. From a corneal foreign body, it translates into a corneal ulcer, and by the time the patient reaches you, it might have perforated as well. Toxicity. Herbal plants can have toxicity. Drug interactions we've already talked about, and lack of regulation. Any nook and any corner, you will find medicines sold as herbal and Ayurvedic products with no validity at all. So what do we need to do? We need to counsel patients on their risks, we need to monitor the adverse effects, and most importantly, we need to have evidence-based integrative care. If we talk to our patients, they will know about it and they will use it with our guidance and in a better way. So we have what is called as integrative ophthalmology. It needs multidisciplinary research. We need clinical trials which are rigorous, double-blinded, randomized. We need to counsel patients that this medicine is okay if you use it along with the standard care, and this medicine is going to cause you harm. Personalized medicine. We need to talk to our patients. And for the government, there needs to be a regulatory oversight. So coming to the key insights, CAM therapy is used by the ophthalmology patients, and in some diseases, it is said to be beneficial. The most prominent among them is the REDS study. Most CAM practices, they lack high quality clinical validation, which is the need of the hour. Ophthalmologists should recognize the prevalence of CAM and maintain an open, non-judgmental communication, because most of the time patients will not tell you they are using CAM because they are scared that you will judge them for it. Patients need to be aware of potential risk and interactions. Rigorous research is important, and we need to have evidence-based CAM, which is the way of going forward. These are a few of my references. Thank you so much for your patient hearing. I invite the next speaker. So we conclude the session. Yes, absolutely.